So if anyone hasn't submitted their English names to our staff, please do so at the registration counter. So for this final session, please welcome back Associate Professor Antonio Vigano to talk about the administration of medical cannabis.
So, congratulations for surviving up till now. And so my also understanding is some people will not be around tomorrow. So I wanted to perhaps to give an opportunity to answer questions that we were planning to, to go over tomorrow. So please don't hesitate to stop me, to raise your hand, make a question. I will probably come down because I can hear better when I am down than I am up here. And so we'll make, more interactive for you. Okay, so I used to have my screen here, but it's not there anymore. I don't know what happened, but I will go like that. Okay, so we're talking about administration of medical cannabis in terms of further developing the concept that we have already said. We hope that by repeating certain things that will kind of come down and settle better with you. My disclosure. So the real objective is, what does it mean a structured assessment and a structured protocol treatment plan in practice? And not just for cancer, but also for other diseases, no malignant. And I noticed that there are some anesthesists here so that they will perhaps enjoy that part as well. So the first thing that I tell my patient who comes with a lot of expectation about cannabis, I look at them and say, I'm happy to care for you, but don't think at medical cannabis as a miracle overnight. What that means is real, that cannabis may help somehow. In patients could be 70%, in others 60%, in others could be just 20% in relieving their suffering. So there is not a guarantee that we'll have a complete success, number one. Number two, it takes time. It's a process. So patient that expect, next week I will feel better, well, I have to tell them, look, our first goal is to have your body adjust to that medication. So we may just spend a couple of weeks just rising very slowly the doses so that you get tolerant to the side effects before going into a therapeutic window. Okay? So the other thing that is very important, they understand there is not a magic number that will work for everybody. Some people may respond very quickly and very small doses. I am also surprised. How come such a small dose is making such a big difference? Could be a placebo effect, I don't know. But for other patients, may require, a month before we find the right dose. Okay? So nothing is predictable, really, at least for our knowledge at this point. And that is a mantra for cannabis, that was already explained or presented by Virginie. Start low, go up slow, and keep low. So use the minimal effective dose. And we'll see why that is important as well. So what I'm presenting is actually a part of a prescriber book that we put together with Sante Cannabis. There might be some agreement in which we may be able to make this book available to you. But so far, you have already something, and so that would be useful, you know, on this part that have been. The person there is Dr. Michael Dworkin, who is my mentor and is one of the founder of Sante Cannabis. He's a medical director. I am the research director, but definitely, you know, a pillar in at Sante Cannabis. So, we are looking at understanding about two issues or two main concepts. One is the type of chemovar, as we call it. So, whether the product is a THC rich meaning that there is still a bit of CBD, but to a trace, which is negligible. For the CBD rich products, the same applies. There is a THC trace, but it's negligible. However, when we use very high dose of CBD rich products, we may start seeing also an effect from the THC. So that is something to keep in mind, particularly for patients who are very sensitive to THC or to patients who are younger than 25 years of age. Why? Because THC is relatively contraindicated for patients who are still developing their central nervous system, as it happens until 25 years of age. The other concept is route of administration. For most of us, this concept can be explained in the same way by which we explain the use of long-acting medication and short-acting medication to treat chronic pain. Why? Because the way that we use long-acting medication is to prevent the symptoms. Meaning that by around-the-clock administration, we can keep lower the doses because we prevent rather than treating the symptoms. At the same time, though, there are moments where the pain breaks through and we have to use breakthrough analgesia. Do you think that an oil will be a good way to control breakthrough pain? I just wanted to ask you. Who can answer that question? An oil works like a long-acting medication. Do you use long-acting medication to treat breakthrough pain? No. Because it will take probably 2 or 3 hours to be effective, number one. Number two, it will not increase effectively the bioavailability of a medication to treat the pain crisis. That is why we use the inhalation route or the spray route, because the onset of action takes between 15 to 30 minutes for a spray and lasts up to 4 hours. Now, why the spray? Because if you are, again, with other people to start even vaping in a very sort of discreet way, everybody will notice that you're using cannabis, okay? And it's still an issue. So that is why we are encouraging more and more to use spray, and we will probably look at new ways like a buccal administration of cannabis, you know, like sublingual use of different products, so to help, you know, with a breakthrough administration. But that is what it is. For pain, for other symptoms like anorexia, we'll see at times what works better is a combination of an oil, long-acting, with a short-acting. Oops. So this is like essentially to, you know, you can follow it, you know, some bioavailability, pharmacokinetic. These information are also important when we are using cannabis in combination with other medication. Because judging from the pharmacokinetic, you can also predict the pharmacodynamic. And that is important, when we are looking at preventing side effects. Particularly in cancer patients who normally are taking many other medication, including chemotherapy. So, treatment selection. These are different conditions that I will review in order to give you a flavor on how we go about. It's obviously something a bit theoretical right now for you, but just to give a flavor how we can, help with these conditions. Chronic pain, cancer, non-cancer. So the goals, again, thank you for fixing the screen. The goals are, again, not necessarily to limit or to treat the pain, but also to allow the patient to be more functional, to allow the patient to, have a better quality of life. At times, patients ask me, well, can I stop all my other medication and start cannabis? I tell them, our goal is to improve your quality of life, which may also improve or decrease the use of medication, but I'm not giving a guarantee about that. So patient needs to realize cannabis is still a complementary treatment. It's not necessarily an alternative treatment. In certain patients may become so, but it's not very old. So what are we looking at considering cancer-related pain? We have these three types of pain: somatic, nociceptive, visceral, and neuropathic. So we know that the neuropathic pain may have some indication, particularly because it's a bit challenging to control with other medication. Now, this protocol is based on what we have available in Canada, which is nabiximols, or Sativex. Sativex is a balanced combination between THC and CBD. And why we use it? Because it's a spray, even though it's a short-acting and short-lasting, still it can last up to 4 hours, for sometimes 6 hours, but it could be already something to use also on a regular basis, like twice a day or 3 times a day, so it can be considered as also for preventive treatment. Now, it's obvious that you don't have Sativex, but you have a balanced oil, so that would be good. And at times, we use also a THC-rich product, which actually is not a THC-rich, but is a THC analog, which is Nabilon, and we use it for different reasons, particularly because of traveling, Nabilon, you can travel, you can cross a border, nobody will know that you are somebody like that looks or works like cannabis, and is a prescription, You cannot do that with a natural cannabis product. So we use that as an alternative. One thing that we like to consider is the possibility of varying the ratio between THC and CBD. It's obvious that for patients who are quite sensitive to THC, we want to reduce the use of THC as much as possible, or patients that want to be active, meaning that patients that have to drive, or patients that have responsibility, or are still working. So what we want to do is to try to increase the amount of CBD and decrease the concentration of THC as much as possible. That is why when we have a patient that is, as we say in Canadian language, on the ball, we then recommend this patient not to buy a fixed product with THC and CBD, because as you can imagine, when you have a fixed product, you cannot increase one component without increasing the other. So you're stuck. And there are certain patients who just cannot increase the oil, the balanced oil, because they get side effects from THC. So in those patients, the only option that we have is to increase the CBD component. And we can do that only if we have the two products in separate bottles. Or we have a one-to-one product and then a CBD-rich one that we can add on top of the one-to-one. And the goal is to altering this ratio, going 1 to 2, 1 to 4, 1 to 6, 1 to 10 between THC and CBD. Now, again, we have a regular administration and we have a breakthrough. And the breakthrough has to be spray or inhalation, and it can also be a balanced product. So when you will have your pharmacist working very, very actively for you, you will ask her to prepare a spray, okay, that will be used for breakthrough administration. So many patients that comes to, in the hospital, I only see cancer patients, but at Sante Cannabis, I see everybody. One particular condition that seems to benefit quite a bit from cannabis is fibromyalgia. It's a very difficult, complex syndrome to exactly classify. Sometimes it's a diagnosis that you do because you don't have any other things to explain what the symptom that the patient is experiencing, but I can tell you it's very, very handicapping many patients, and it's a very important, diagnosis in terms of impact. The other things that we, and of course, these patients suffering from fibromyalgia are often young patients, not necessarily very elderly, old, or sick. So we want really to restore their ability to function, quality of life, etc. We have also pain from neuropathic diabetes with chemotherapy-induced peripheral neuropathy. I think we have another slides as well. But again, the suggestion is to start with a balanced product. When I have the option, I still like to start with a CBD-rich product because there might be that patient that responds well to CBD alone, and that is a jackpot, okay? Because that patient will not have to endure the side effects of THC and have just the benefit out of a CBD-rich. But, at Sante Cannabis, we tend to advise in general more for a one-to-one product, particularly because, to buy 2 bottles is like expensive. So you want to maybe go with 1 bottle that combines the 2, which is easier for the patient. So again, the combination, oral and inhaled or spray, is the one that works the best also for chronic pain of neuropathic nature. We have a lot of elderly patients. They come with diffuse osteoarthritis. They come with other conditions, GI related, and which are characterized by an inflammatory response. When we consider the anti-inflammatory effect of cannabinoids, we are looking at a specific effect, which we call immunomodulation. And that is very different from what we see when we give the usual anti-inflammatory, whether those are simple anti-inflammatory over the counter or disease-modifying medication. What it happens with a conventional approach, you just lower dramatically the inflammatory response. But that inflammatory response has a purpose. So what cannabis does, particularly in the patient that it works, it kind of immune modulates. That means that will rebalance the way that the body uses inflammation as an homeostatic system. So will repress the component of inflammation that are overexpressed and enhance the component of inflammation that are under-regulated. Okay, so it's re-establishing an homeostasis rather than cutting completely the way that the body works. So it's obvious that in your case, you will have to start with a one-to-one product. Probably the THC by itself may not be effective in that domains, but in HIV patient, I've heard that the THC is also a potent immune modulator as well for the inflammatory response. So again, we look at either CBD or THC and CBD, and again, the advantage of starting, with one product which has only one component, like CBD rich, is that you may understand a bit better what works by using a sequential approach rather than starting with a one-to-one product right away. Sequential meaning starting with CBD alone and then adding CBD and THC. I wouldn't say that THC alone will have a big role, although there is some evidence and it's something that could be considered. But in general, I will use a balanced product if I have not a CBD product available. Any questions so far? Everything seems okay, except that this is not going forward anymore. Oops, okay. Yeah. So nausea and vomiting, it's important to remember that Nabilon and Dronabinol, which are the only synthetic THC analog, they were labeled for chemotherapy-induced nausea and vomiting, okay? But it's important to remember, as I mentioned to somebody already, that only 5% of the time we use Nabilon for that indication. 95% we use for all other indications that we discussed about. In general, it's the THC that works for nausea and vomiting, as also suggested by Nabilon, but I've seen patients doing very well on CBD-rich products. In any case, in your case, it's not an issue because it's not available. You may try just THC first. That probably will be the best available treatment, more available or most available treatments. One important thing about chemotherapy-induced nausea and vomiting is the anticipatory effect or the anticipatory nausea and vomiting. That is where cannabis works the best because of its anti-anxiety / depersonalization effect on the experience related to chemotherapy or to the suffering related to the treatments. Okay. The important aspect is that patients on very high dose of THC, and again that is called biphasic effect, will actually have emesis induced by cannabinoids, okay? So there is also an issue with potential hyperemesis from higher THC consumption. Appetite stimulation, again, we have seen that the main way that THC works is through stimulation of production of ghrelin, which will become more its effect will be enhanced in cancer patients. We know that some of these patients have already a hypersecretion of ghrelin, but they just become insensitive to it. So the THC may work also restoring sensitivity to ghrelin. Those are all important conditions, HIV, AIDS, anorexia nervosa, and again, appetite is often related to anxiety, is often related to a particular problem, psychiatric problem, which may respond positively to THC. And again, for patients that are particularly sensitive to THC, combining it with CBD would be also okay. Anxiety, you see all the list. For anxiety, the best medication is really, the best product is CBD rich. If it's not available, use small dose of THC is also a possibility. Again, remembering that there is also a biphasic effect of THC. Small dose are anxiolytic, higher dose may become anxiogenic, okay? PTSD, very, very effective with THC-rich products, Nabilon being the first one, particularly at night, depersonalization of the stress experience, and really incredible, response. Again, not in all patients, most patients, to this problem. Sleep, again, at times we may look at what is the driver of sleep issues. As palliative care physician, we know that if a patient is not sleeping because has pain or has another symptoms, we need to treat the symptoms. In general, anxiety may respond well to CBD, but also what is probably the most used approach with natural products is a one-to-one product. So that would be our first choice. We have always to remember that the sleep disturbances may have an impact on the ability of a patient to fall asleep and the ability of a patient to stay asleep. So that is important because if a patient has difficulties to fall asleep, it takes an oil and will have to wait 2 hours before falling asleep, okay? Because that is how the oil works. So if a problem is really falling asleep, inhalation or spray should be used, short-lasting and short-lasting. Now, if a patient has trouble staying asleep, it's obvious that, the short-acting ways will not be effective. The patient will wake up after 2 hours. So we need something to prolong the effect, and the combination of the oil would be a good strategy. So it's primarily, CBD and THC and CBD, sometimes high dose of CBD or small dose of THC may also work. Nabilon is not available to you. Spasticity, I'm not sure if that is of interest, but again, we try primarily combination products that could also apply to Parkinson issues, Parkinson problems, and so the combination is what we use the most. Migraine headaches, I'm more in favor of using a combination, one-to-one, because there is always a sort of triggers, could be anxiety, could be other things, so CBD would be a good addition with THC being the one that works best on migraines. And again, we are looking at prevention with a sort of regular administration or treating just, crisis. It's obvious if the migraines are happening once a month or twice a month, there is no point to take a regular product all the time to prevent that 1 or 2 episodes. But if, so just a PRN, spray would be fine. But if migraines are more often recurring and things, then, it would be indicated to use irregular products. And on top, we use a PRN. Epilepsy, I'm not an expert. It's Dr. Michael Dworkin who follow patients. But there is the protocol suggested for treatment. Again, very important to collaborate with a neurologist or family practitioner attending the patient in order to coordinate treatments, particularly with pediatrics population. So, dosing instruction. So, again, we have the vaporization. You can read the fine, instructions. Again, we consider primarily inhalation as a breakthrough, as needed dose, and we have to allow patients to understand what is working for them, what is the dose. So, this is our recommendation. When patients are particularly sensitive to THC, then we have to, again, make that combination, different ratios. So these are titration oils. I mean, you can read again, the most important aspect is to start low, go up slow, and keep low. And always look at milligram of product. ml, milliliter may become confusing unless the patient is, unless you have only one product that you're using all the time, for which you know exactly what is the concentration. Otherwise, you have to think at milligram rather than ml. And again, when you have issues with organ failure, then you have to look at, adjusting your way, which is, as was mentioned before, starting at lower dose, going up a bit slower, and reassess the patient frequently. So this is something that you can look your own on. The most important thing when you do the titration is to look at the THC component. That is the one that you have to keep an eye on, rather than the CBD, okay? Because it's the one that can provide more issues. We have, once a day administration, 3 times a day, or twice a day. Age, an important factor. For patients above 80, I only go with once a day administration. Patients who are 70 and 80, I probably will stay twice a day and not 3 times a day, just to avoid problem with pharmacokinetic. THC rich, again, you keep an eye on the THC because it's the only one that, and again, this is the titration. And in general, in Canada, we have products that are between 20 and 25 milligram of THC per ml. So that makes it easier for us to understand the dose. That would be very important from your pharmacist to understand what is their concentration. So that has been already discussed. I would, would say that cannabis has been proposed as an opioid substitution. But we have to understand that if somebody is addicted to opioids, there's a high risk to become addicted to cannabis as well. So it's not that, cannabis is like a walk in the park. We have to keep always in mind the harm reduction strategies, which are meant to keep the risk of addiction and the risk of becoming tolerant to cannabinoids the lowest possible. And very important to remember about asking the patient about previous experiences with cannabis. It's very important. At times, a patient comes and it looks to both of us perfect for a THC product because, I don't know, has just lack of appetite, has nausea and vomiting, cannot sleep at night. But then we ask the patient, did you ever try cannabis in the past? Oh yes, I tried, and I couldn't really take anymore because I was feeling so depressed, so withdrawn, that it was really a nightmare for me. It's obvious that that is a very important information that changed completely our strategy for that patient, even if indication was THC. Concurrent medication, particularly with anti-epileptic medications, we have to be very, very careful, and particularly with CBD. CBD is the one that will impair the most in terms of metabolism of anti-epileptic medication. And most of the times we see side effects from CBD administration, not because of the CBD itself, but because the other medication become overdosed because of an impairment in their metabolism by the CBD. So these are other important. And again, we have contraindication, but we have also limitation of precaution. So that means that, there is not necessarily a contraindication for cannabis, but you need to be aware of certain, possible risk that, that we explain. Suicidal ideation is something to consider. Cannabis, particularly THC, can push patients over the limits. Bipolar disorders, schizophrenia may really imbalance the patient to that extent that, we can go into trouble. So treatment plan, we kind of discussed a little bit before. So we need to decide, route of administration, type of products, patient ability to handle cannabis. Now, in Canada, we have soft gels, which are very practical, because it's mostly like a medication. However, to titrate somebody on soft gels is not that easy, because the oils allows you a much finer titration. Once the patient is titrated, then it can be switched to soft gels. It's about like long-acting administration for opioids and short-acting. Follow-up and monitoring, very important. Objectives, whether the objectives that were indicated at the beginning were met. At times the patient comes back and say, doctor, I'm not going well. And I say, why? Because I have more nausea, I have more let's say anxiety, and I cannot sleep at night. Oh, but which were the problem when you came? Oh, before, the patient may have forgot. It was maybe pain. It was maybe appetite. But now those problems have been taken care and other problems have risen, and then you have to adjust your treatment. So there is a paradigm shift, and that has to be documented. Otherwise, you will feel that you're not doing anything or you're doing all wrong. Okay, some strategies to decrease side effects. In general, the mostly used strategy when we do a titration and the patients start to have side effects after a certain level of titration, what we recommend the patient is to go back to the previously tolerated regimen, stay on that regimen for maybe another week rather than going right away to the next step in order to get more tolerant, and at that point try to raise again the product if the desired effect was not met or reached. We have again reduction of THC, increase of CBD to increase the tolerability. We have all these possible strategies which are primarily meant to decrease the dose of THC. But again, you can reduce the dose to THC or increase the tolerance to THC by staying more, longer on a certain treatment tolerated or adding some CBD. However, we have some CBD-related side effects. Aside from the pharmacokinetic implication that we are going to see, but CBD-rich products in Canada are mostly hybrid. And this means that, yes, they can be used both during the day and at night. But for instance, in cancer patients who have already trouble with fatigue, the CBD can increase that fatigue. And that is obviously not a good thing for us. We have ways to decrease the CBD, to prolong the interval for different doses. So we have a way to deal with this problem. But something to remember, that is this part of our armamentarium. So you can see that the managing cannabis, yes, is a science, but it's also an art, okay? And we have all these strategies. These are the different clinically relevant interaction, primarily pharmacokinetic interaction, but there are also the pharmacodynamic interaction. So if we add cannabis to an opioid, we may see that irrespective of the pharmacokinetic, the patient may become more somnolent because there is a pharmacodynamic interaction. So something to consider as well, possibly. Different enzymes involved, which are different for different medication. And I never remember, I have always to go back and check for interaction. That, to close, I would like questions from you. I know that it's easy when you see patients and you have your own experience to discuss the different approach, but I would be very happy if you have any questions to start, particularly if you're not coming tomorrow, where we'll sort of discuss specific clinical case.
Okay. Thank you, Dr. Antonio. Please give a big hand to Associate Professor Antonio Vigano. So, are there any questions? Especially for those who won't be joining us tomorrow. Oh, okay.
I think we are a bit tired. It was an intense day, but thank you for your participation.
Okay, thank you very much. So please give another round of applause to both of our speakers today who have been with us all day today. Thank you so much. So just to close and to remind you, tomorrow's workshop will be held on the third floor in room 326. The registration begins at 8 a.m. and the workshops begin at 8:30. So we'll see you again tomorrow. Thank you so much. ขอประกาศอีกนิดนึงนะครับท่านใดที่ยังไม่ได้กรอกแบบประเมินนะครับกรุณาช่วยกรอกแบบประเมินให้ด้วยนะครับที่ข้างหน้านะครับขอบคุณครับ